Thanks so much for that welcome. And I'm really excited to be here and talking to you all about trauma-informed care and the neurobiology of trauma and how that might show up for the patients that you all are seeing. You've already heard that you may be filmed or photographed, and I do not have any conflicts of interest or will be discussing any off-label product use. So we can dive right in. Well, before we get started, I think anytime we talk about trauma, it's really important to me that we take a moment to recognize the impact just talking about trauma can have on all of us as professionals. And the reality is that most people have experienced a potentially traumatic event over the course of their life. And given the nature of the work that we all do, we often have the experience of either seeing something traumatic at work or hearing about somebody else's trauma. So during this talk, please be sure that you are taking care of yourself. So if you need to step out and use the bathroom or get a drink of water or space out for a minute and not pay attention, that's totally fine. Just make sure that you're doing what you can to take care of yourself as we talk about this today, and also pay attention to how you're doing after this talk later on today. Sometimes it takes a little while for information to sink in and for people to connect how it might be impacting them. So please make sure that you're taking care of yourself today, both throughout this talk and later on as well. So in terms of our objectives, we're going to identify at least 3 signs of a trauma response, identify at least 3 principles of trauma-informed care, and 2 ways to resist re-traumatization for patients, for their caregivers, and for our staff. And as we talk about everything today, I want you to keep 4 groups of people in mind. First is patients. Second is their caregivers and families. Third is other staff members, and lastly, 4th is ourselves, because we are all impacted by potentially traumatic events too. We're humans, and being able to pay attention to the ways in which our own stress response is activated based on the things that we're seeing is really, really important and helps us be more trauma informed with our patients and their caregivers and with each other. What is trauma-informed care? At its core, trauma-informed care recognizes that traumatic experiences terrify, overwhelm, and violate the individual, and therefore is a commitment not to repeat these experiences and in whatever way possible to restore a sense of safety, power, and worth for our patients. And as we move this today, we are going to use the Substance Abuse and Mental Health Services Administration's definitions of trauma-informed care. And SAMHSA has these 4 R's that help us really break down what is trauma-informed care. The first is to realize, and this is realizing what is the impact of trauma, how does it impact our patients, their caregivers, ourselves, other staff members. So that way we can really understand both how widespread it is and then also how it might show up with the people that we are interacting with. The next is to recognize signs and symptoms of trauma in patients, families, and staff, and ourselves. Then is responding by fully integrating knowledge of trauma into policies, procedures, and practice. And last is resisting re-traumatization of patients, families, and staff. So we're going to start and really break down each one of those R's so we can think about how that applies to the patients, families that we're working with and to the other staff members and ourselves. So when you hear the word trauma, what do you think? And you can either throw it in the chat, you can come off mute and say it out loud. What do you think of when you hear the word trauma? Painful experiences, something in the chat. Grief, yep. What else? Disconnection. Any other thoughts? Abuse, psychic pain, separation from peers, unintended injury, absolutely. Lack of trust, safety, abuse, neglect. These are great examples. Thank you. Terrible event of some kind. Yep. Great. So let's think about trauma. SAMHSA, again, gives us a nice scaffolding for how we think about it. And so to really think about what trauma is, we chunk it into 3 things. The first is the event itself. And you all gave me a nice list of those potential events that could qualify as trauma, right? The next is the experience of events. And then the last is the effect of the experience of the event. The reality is that our experience of an event could be pretty dramatically different based on our past history, based on just simple things like if we were all in a room together, where we are in the room, we might have a different vantage point on something that's happening and therefore might experience it differently. Um, our developmental level, for example. So if you're thinking about the kids that you're working with, developmentally, we might have a different understanding of what's going on, and also developmentally have more capacity to be able to deal with stressful experiences the older that we are, right? And the more our brain is developed. So with all of those three things in mind, you can imagine that the same event could actually be experienced pretty differently by different people and then lead to different effects as well. So we keep that in mind, that what is potentially traumatic to one person that makes a really big impact might not seem like that big of a deal to somebody else, and vice versa. And so to me, the event itself is less important than the experience of it and the effect long term. So in terms of understanding how widespread trauma is, the reality is it's very widespread. 2 in 3 children will experience something traumatic by age 16. Whether or not their experience is that it is traumatic is a different thing. But knowing that, we know that at least 2/3 of kids have something that was potentially traumatic. And when you think about that for adults, it's about 70% of adults have experienced at least one trauma over the course of their life. We also know that trauma disproportionately impacts people of color, women, people who identify as LGBTQ, not because race, as an example, is a risk factor, but racism is the risk factor, right? Sexism is the risk factor. What discrimination, racism, sexism, homophobia, all of that is traumatic. And it is important to recognize those experiences as being trauma. We also know that at least 64% of people experience at least one adverse childhood experience during childhood. So let's talk a little bit about what ACEs are. So ACEs are these adverse childhood experiences. The first ACEs study was done through the Kaiser Permanente system in California and really surveyed, I think, over 60,000 people to get a sense of how these kind of core early childhood experiences that you'll see in the tree here, in these household experiences, how they impact long-term health outcomes. And what the study found is that the more adverse childhood experiences that you have, the more likely you are to experience poor health, poor mental health, as well as early death. And as more and more research has been done around adverse childhood experiences, we know that it's not just these original 10 things that included things like divorce or an incarcerated family member, neglect, abuse, sort of all those core things that you all identified earlier. We also know that adverse childhood experiences really includes a lot more than that. So you'll see also in this image, adverse community experiences as well. That's the soil this tree is growing in. So if you're a youth who is living in a situation where you're experiencing structural racism, where you have historical trauma, both in your family or potentially in your culture or your racial ethnic group based on racism that has been experienced, or sexism, homophobia, all of those types of things, that is going to impact your experience of the world. I think about transgender youth and gender diverse youth right now as an example, with all of the many laws that are being passed to restrict rights for that group of kids. That's part of that adverse community experiences of rejection and feelings, potential fear around what could happen to them, all of those types of things. We also have adverse environmental experiences like climate crisis, wildfires and smoke, pandemics, earthquakes, right? And some of those things are disproportionately impacting different groups of people based on where you live, based on how privileged you are, all those types of things. We know that people who live in poverty, women, girls, LGBTQ individuals, ethnic minority groups are more likely to experience ACEs because they are more likely to be targeted with discrimination, with violence, those types of things. So really important to keep all of this in mind. Let's turn a little bit now to medical trauma. Medical trauma is trauma that's experienced after pain, injury, serious illness, medical procedures, any frightening treatment experiences. And this can be trauma not only for the patient, but also for their caregivers. And a diagnosis itself can be potentially traumatic. So just hearing that you have a life-threatening illness, that in and of itself can be something traumatic both for a patient and also for a caregiver. And knowing that, I think of the context in which we meet our patients. Just walking in the door of a hospital as an example, people are coming to us with something potentially traumatic, even if nothing else has happened in their life. Just the very reason for why they are here is potentially traumatic. And so it's our job to think about how we can make this experience as least traumatic as possible. We also know that many ill, injured children and their families, up to about 80%, experience some sort of traumatic stress reactions following a life-threatening illness, injury, or painful medical procedure. This is from the National Child Traumatic Stress Network, which is a really excellent resource. And I've got a bunch of resources at the end of these slides for you all. NCTSN really has very wonderful tools if you want to dive in more about trauma-informed care. And then as we think about caregivers and families, 20 to 30% of parents and 15 to 20% of children and siblings experience persistent traumatic stress reactions. So that means not just for short term, but long term, that these folks are experiencing traumatic stress reactions, impairing their daily functioning, affecting treatment adherence and recovery. This is for caregivers and for siblings. We also want to think about the impact of trauma on staff. And so as we think about how this impacts staff, we think about it in a number of different ways. Secondary trauma and vicarious trauma are thinking about what happens when you hear about somebody else's traumatic experiences. Or what happens when you see something traumatic at work, and then how that accumulates over time. And sort of compounds when you hear about these stories or see painful medical procedures or have to deliver hard news kind of over and over, right? And that can turn into compassion fatigue. As we have to harden ourselves to protect ourselves sometimes from doing this hard work, that can lead to indifference to other suffering, right? We put a little bit of a wall up so that way we don't get impacted so much, but then that can mean that it takes a lot of something to happen before we feel anything about it. And it's a really good thing for us to all be paying attention to. When are you getting into that realm of, all right, I put lots of walls up so that way I'm not hurt by the work that I'm doing, but now I'm falling into this side of compassion fatigue. And then all of that can lead to burnout, is that physical, emotional exhaustion that can come as a result of prolonged stress, frustration, that kind of thing. Any thoughts about how we can realize the widespread impact of trauma, how it impacts patients, caregivers, staff, ourselves, before we move on to recognizing signs and symptoms of trauma? All right, I'm going to keep plugging away then. So our second R is recognizing the widespread impact of trauma. And the key takeaway for this for me that I would love for you to all think about as you move forward is that the effects of trauma are normal reactions to abnormal events. Our bodies are hardwired for survival. What that means is that we are going to pay better attention to things that are a threat to our safety than we are going to pay attention to things that are more pleasant. Like our bodies just do that. Our brains do that. We just pay attention to the bad stuff on purpose, because the more we pay attention to the bad stuff, the more likely we are primed to avoid those types of things in the future. So what I'm going to ask you to do now is think a little bit about how our body works and why this makes sense. So polyvagal theory was really coined by Stephen Porges. I have a link to his chapter on A Primer to Polyvagal Theory. But basically, this theory is all about the way our bodies are hardwired to respond in moments that are potentially traumatic, where there's some threat to our physical safety, loss of life, those kinds of things. That's what our bodies are hardwired to do. The reality is that we also have this autonomic nervous system go off in times where we don't necessarily have a threat to our life, right? The challenge is that when we've lived through something traumatic, or have heard about other people living through traumatic things, our autonomic nervous system gets primed to react quickly and to react frequently, so that way we don't have anything bad happen to us. So what I'm going to ask you to do now is to imagine that you have a bear coming at you, because this is going to help us think about why a traumatic stress response actually makes a lot of sense. So if a bear is coming at you, you have a number of different options, and you have to react really quickly, because if you don't react quickly, you will get eaten by that bear. So the first thing that you can try is you can run away. If you are fast, if you have enough lead time, you can run away and hopefully avoid anything bad happening to you with a bear charging at you. What this can mean is with your autonomic nervous system is that your muscles get tight and tense, your breathing gets faster. Basically, all the things that need to make your muscles go and work quickly, your heart rate increasing, happen so that way you can be super speedy and get out of dodge from that bear. The other thing that happens is that the parts of your body that you don't need to be using while you're running away from a bear get shut off. So you don't need to digest your hamburger while you're running away from a bear. So you get butterflies in your stomach, you get a pit in your stomach, sometimes people throw up, get nauseous, all that kind of stuff, right? And flight can look like actually physically fleeing, but it can also be avoidance, right? And so what I'd like you to do now is think about, how does the flight response show up in patients, in caregivers, in other staff members, or in yourself in difficult, stressful situations. Things that I've seen as kids quite literally running away, but that's the extreme version of the flight response. I'm seeing in the chat denial, absolutely. Denial can be one. I think avoidance of a topic, trying to change the subject. Yep, anger can be part of that for sure. Yeah, avoiding classes for sure. Avoiding things that you know might be unpleasant. In the moment, like getting on your phone, right? Have you ever had to have a difficult conversation with somebody and all of a sudden they're on their phone instead of paying attention to you? That could be part of the flight response. Any other ways we see flight come up? All right, I'm going to keep plugging along to the fight response. So the fight response, bears coming at you, you do not have enough time to run away. So potentially what people can do in this moment, or animals, is fight back, right? And if you're big enough, if you're strong enough, you might be able to prevent any harm to yourself if you fight back. And similar things happen in your body as with the flight response, all those same things: muscles tight and tense, breathing faster, heart rate increasing. Also, one of the things I failed to mention before is, like, you get a little bit of tunnel vision. You're not thinking things through very clearly because you have to react super fast. You cannot think like, what's the best choice in this situation with a bear running at me? You just have to react quickly. Since you have to react quickly, you're not thinking things through of like very carefully about what to do. And so that fight response can look like actual physical fighting on the PBMU, the inpatient psych unit, where I spend the majority of my time. Sometimes kids do charge after one another when they feel slighted or they're in an argument, and actually like get to a point where they want to be fighting. That's, again, the extreme version of the fight response. But this also can look like anger, yelling, posturing, those kinds of things, arguing. That can be that fight response that comes up. And so I'll ask you to think about, for you, with patients, with caregivers, other staff members, yourself, what does that fight response look like? How does that come out? You can type in the chat, you can come off mute. Yeah, punching walls, absolutely. Defensiveness, for sure. Blaming, yep. Yes, rationalizing, being stubborn, all of these are really great examples of the fight response. All right, for sake of time, we're gonna keep moving through. So the next response is the freeze response. So think back to that bear. Say you are not fast enough to run away, you're not big enough to fight back. the freeze response might kick in. And this is when you might hide, you might play dead. Think about like a possum playing dead. That's kind of a perfect example of a freeze response, right? That this would make a bear either pass by you because they don't see you, look at you and be like, that's not worth my time because it's already dead, those kinds of things. And the freeze response shows up a lot, especially for the young kids that we work with who don't have a lot of power and control because of how small they are or how young they are, right? And this can show up as literally appearing frozen. So you may have worked with folks who get hard news and they just don't respond, and you look at their eyes and they kind of just don't even look like they're there, right? So that can be called dissociation. And when people are dissociating, I think of it as like extreme spacing out. We all do it. Every single person dissociates. It's actually our first coping skill. If you think about a baby, for example, when babies are really young, they can't crawl. They just have to like wait for somebody to meet their needs. And their first step that they can do if they have a need needs to be met is they can cry. And then if their need isn't met right away, they can either keep crying and make themselves hysterical, or they can stop attending to whatever's happening, and then have a little bit less distress in that moment. And that's the kind of early ways in which we all dissociate, and we all do it. And it is pretty protective too in the moment if something bad is happening to you. If you are frozen and not paying full attention to what's happening and doing that sort of extreme spacing out, you don't remember in clear details what happens. And that kind of protects you a little bit from remembering those pretty awful details of bad things that have been happening. And when people have experienced something traumatic, and especially if there's somebody who is more likely to use this freeze response, something can trigger them, and then they can go right into that dissociative episode freeze response where they're not responding, they appear like they're not there, they might like actually look physically paralyzed in the moment, that kind of thing. Not knowing what to say, all of those can be good examples of a freeze response. So I'll ask you to think about in your settings, what have you seen that might look like the freeze response with kids you've worked with their caregivers, with other staff, and yourself? And either think about it to yourself. You can also put it in the chat if you have any ideas. Yeah, a lot of moving freeze, hoods up, hats, masks, hair over faces. Yeah, kind of like that inward isolation. And I'm seeing unable to answer questions, giving I don't know answer to every question, changing the subject. Yeah, getting on a verbal loop, getting kind of stuck. That's a good example. All right, great examples of the freeze response. Fight, flight, freeze are the ones most people know about. We have 3 more Fs to get through. And so these next 3 might be a little bit more than you've heard about before. So if you do have any questions, feel free to throw them in the chat as we go. So this next one is the flood response. And so with flooding, this is basically when you are so overwhelmed by emotion in either in the moment when you've had something potentially traumatic happen, or sometimes our body kind of like helps us hold it together until we're safe. And then all that emotion comes out after the fact. So I'll share a personal example for that. A few months ago, I was driving home from picking up my kids from daycare. They're 2 and 5 for reference. And I had them in the back seat, and I was driving down Lake City Way, and there was a lot of traffic in my lane, but the lane next to me didn't have much. And a car pulled up next to mine, even though they had about 10 car lengths ahead of them. And we just sat side by side, and it was an older man who just stared at me and didn't move his car up, even though he had plenty of room to. And he just stared. It felt like forever. It was probably only a short period of time, but it was really creepy. And then looked like, as we started to move, like he was going to try and follow me. So I felt really unsafe, and also had my kids in the back seat and was thinking not only of my safety, but of their safety as well. So in the moment, I was able to use my flight response, honestly, and get out of that situation and put some cars between us so that way he couldn't follow me, As soon as I got home, and was safe and saw my partner, I couldn't even tell him what happened. I just started crying and like couldn't even get out what had happened because I was just so overwhelmed by sort of that emotion coming out. Like we were safe, things were okay, and I was just really flooded with emotion. And it took me a while to be able to calm down enough to tell him what had happened. And that flood response can sometimes happen immediately for people, but sometimes it's a little bit delayed. And so as you think about people that you've worked with, you can think about what has that looked like? And maybe it's delivering hard news to somebody and they immediately go to crying or screaming or yelling, and just having an outpouring of an emotion. Maybe it's not that flood response is delayed and in the moment they seem fine or seem like that everything's okay. And then it comes out a little bit later when there's a little bit more safety. So think about with patients, with caregivers, with staff, and yourself, what does that flood response look like? Um, and and either write it in the chat or think to yourself. Either one is fine by me. All right, let's go on to the FAWN response. This is the one that people know the least about. So when we think about the FAWN response, this is when evolutionarily, this one makes a lot of sense because if you are living through something traumatic, especially repeated trauma in the context of a caregiving relationship, where you have learned that maybe people aren't very safe. I think about like an example of a kid who's experienced abuse, for example. If it's a caregiver and they have learned that, you know, when a parent is angry, that bad things happen, the fawn response comes out by being nice to that parent to preemptively prevent them from being hurt, right? And this is sort of a learned response to like prevent yourself from being hurt in the moment. And the way that this can come out when we're working with our patients or with our caregivers is basically like having people seem extra nice, giving lots of extra compliments. And I think one of the tricks about this one that's hard is that people perceive it sometimes as manipulation, like, oh, that person's trying to manipulate me. That's not what it is. This is a survival response that has been learned over time that like if I am really nice to people, less bad things will happen to me. The problem with it is that sometimes we can perceive it as, oh, this person is understanding everything I'm saying. They're on board with the treatment and all of that kind of thing. But actually, they have learned through difficult experiences in their life that they just have to be nice and people pleasing over and over. And so there's an opportunity for misalignment of maybe the patient and the caregiver actually don't agree with what we have to say, but they have learned that they need to be, you know, people pleasing in that moment. And so really important for us to check on, all right, are we all aligned, that kind of thing. The other way I often see this come up is things like, oh my gosh, you're the best nurse that I've ever worked with. You're my favorite nurse. Can you always be my nurse type of a thing? And sort of that like, well, nobody is as good as you. And it's really flattering when kids tell me, oh my gosh, you're the best therapist I've ever had. I get pulled to want to keep being their therapist. And I'm not a bad therapist. I don't know that I'm the best therapist anybody's ever had, though. And I think one of the things about that that's hard is that it does play into our desire to be good at our job, to help other people. And what it can lead to is if you feel like, well, I'm the only person that can help this person, that's a lot of pressure for you and also doesn't allow us to work as a team as well. So important things for us to keep in mind with the fawn response. Questions, thoughts on how this shows up? Any things you've all noticed that you want to throw in the chat? All right, we're going to go on to our last one, which is fatigue. So when we think about fatigue, think about the incredible amount of energy that it takes to have that fight, flight, freeze response go off. In order to help you run away from a bear, you get a surge of energy. You know, think about the examples of like a mom literally lifting a car up off her kids, right? We hear that in the media quite a bit of these like superhuman strength things that happen when people are in crisis. What we don't hear about is the crash that happens after, right? That energy comes from somewhere. And so the fatigue comes sometimes in the moment where, you're triggered to have a trauma response. And like some people quite literally do fall asleep in that moment. But sometimes it's a little bit delayed and afterwards, after that heightened experience has passed a little bit. And so think about, patients or caregivers that you've worked with who um, maybe they're like constantly sleeping when you go to check in on them. And that could be potentially from the stress of all of the things that they're experiencing and their stress response being heightened all the time and just their body being worn down from all of that. Any thoughts about fatigue before we keep moving? All right, let's keep going. So, as we think about the impact of sustained activation of the stress response, so when you are having your stress response go off all the time, which can happen if you're in the hospital a lot, which can happen if you've lived in an abusive home, as an example, or maybe you've had one traumatic experience and that triggers you to constantly be on alert and on edge. Especially for youth and for the kids that we're working with, this can lead to damage and underdevelopment of these different parts of the brain, like the prefrontal cortex, the hippocampus, and the anterior cingulate cortex. And that can then lead to deficits that those parts of the brain are in charge of. So that means things like emotion regulation, our memory, learning and cognition, ability to manage a stress response, executive functioning, which is our ability to like plan, control behavior, those types of things. And what that can mean is that, we might really want a kid to be getting their behavior under control and pay attention to what we're telling them, but they actually can't. Like their brain has not developed in a way that allows them to do that. And so we can see difficulties with our expectation of what a child should be able to do. And the reality of what they're able to based on the impact of that sustained activation of the stress response. So what I'm going to ask you to think about now is what are some difficult behaviors you might have seen patients, caregivers, other staff, yourself engage in that could be better explained by trauma? And I would imagine that we've probably all had many experiences that, of people yelling at us or people really being difficult that are not pleasant and could potentially be because of something traumatic. So I'm seeing projecting blame. Yeah, absolutely. Hitting, kicking for sure. Other thoughts? All right. So what I'm going to ask you to do now is take a look at this image. And as you look at it, there's a few different ways that you can perceive it. And neither neither way to perceive this image is the correct way. Being hit by a patient is not okay. It also can be understood as a potential trauma response, right? Both can be true. And so as we change our perspective, it doesn't mean that we are allowing negative behavior to happen or are allowing ourselves to be targets of violence, as an example. What it does mean is that we have some understanding of like where the behavior comes from and why somebody might be behaving in the way that they are, right? And hopefully, with changing our perspective, we can think about the situation differently. And the other piece to think about that's so important is that through all of this, we all have our own personal stress responses. We are all impacted by the work that we're doing. And so, if we can pause to change our perspective, we might be less likely to, in turn, react from our own stress response. So that way, we can slow down a little bit and not have things escalate and kind of snowball off of each other. So as we reframe how we perceive behavior, can we move from what's wrong with you to what happened to you rather than blaming somebody, but really trying to understand, all right, what's this behavior, what's driving this behavior? From perceiving a behavior as disobedience to fear, potentially, right? Like we had a kid on the PMU who refused to sleep in their bedroom, and we saw them as being disobedient for some time until we realized that they had a history of being abused in their bedroom. And so they were fearful being alone in their room. It makes actually perfect sense that they wouldn't want to do that. And so our ability to change our perception made that we were able to have a different intervention for that kid. And then is it I won't do it or I can't do it? So if we're asking kids to have better control over their behavior, and are we perceiving it as they won't do it, or is their executive functioning having deficits because of early trauma, so they actually aren't able to do it, or developmentally just aren't there yet, or the trauma of the things that they've experienced in the hospital mean that they're in that fight flight mode all the time, right? Thoughts about our ability to recognize trauma responses before we think about how we're going to respond? All right, I'm going to keep moving then. So as we think about being trauma informed, we operate with a universal expectation that all patients, caregivers, families, and staff members have experienced trauma. And if we can operate from this perspective change, think about how that might change the way we interact with patients, with families, and with each other as we talk about these next principles. So, Substance Abuse and Mental Health Services Administration, again, has a framework for us to think about all of this and has identified 6 principles of trauma-informed care. We're going to go through each one of those now and think about how they can apply to the different settings that we work in. One thing that I want to highlight is that they are principles. They are not a how-to guide. There's not like a guidebook of like, here's how to provide safety for every one of your patients. The reality is that with each one of these principles, they're going to be a little bit different based on the patient, based on the family, based on the staff member. And so we need to think about how we can use the principles without rigidly adhering to them, because there's not like one set way to do this. So with safety, we think about predictability and routine. When people know what to expect, that helps them have safety. So if a kid is having a difficult medical procedure, explaining to them, here's what's going to happen. With my own 5-year-old, he really hates the doctor, like a lot. And he has a stuffed bunny that goes everywhere with him. Every time we go to the doctor, that bunny gets checked out in the same way that he does. And over time, he's actually gotten to a place where it's not such a scary place for him, because he knows exactly what's going to happen every time because he sees it happen to the bunny first. So that's one potential tool for ways in which we can help build some predictability and help people have some understanding of what's happening. We also need to think about how do we actually physically provide safety, right? So sometimes that's things like lights. When I walk into the outpatient psychiatry department in the morning, the lights are usually off. I'm one of the first people here. It's dark. It's kind of creepy. As soon as the lights are on, it feels a lot safer, right? So those types of things are really important. And then also that psychological safety. So promoting positive and stable relationships in the person's life to have safety both outside of here. And psychological safety can be providing boundaries and limits. The more we have boundaries, people know what to expect. If we allow people to completely push past boundaries, they learn, well, actually you don't mean it. And so that even though in the moment it might feel like letting somebody push past a boundary is helpful, it also can mean that it's a little bit destabilizing in terms of somebody's experience of safety. The next one is trustworthiness. You'll notice for safety and trustworthiness, there's kind of a lot of overlap here. But for here, I think about predictability. So responses to behavior are expected. I also think about transparency, consistency, having boundaries like we mentioned before, having clear information about when, where, whom services will be provided. That's all really helpful to provide trustworthiness. Following up with people after you've told them that you'll do something, being on time, doing what you say you will. If you can't do it, taking responsibility are all potential examples of trustworthiness. Next is empowerment. So this is how do we empower patients, caregivers, also staff to own the things that they can. And so here we think about how can we build skills in our patients so that way they're in control over their behavior. As an example, they're in control over their own medical care, right? So what are the pieces of their medical care that they can be empowered to have control over? And this is going to be pretty different based on the kid's developmental level. But if you've got a kid with diabetes, what parts of their medical care can they be in charge of as they're monitoring their blood sugar or their insulin levels, as an example? There are certain parts that some kids can take ownership of, right? Um, and then also things like offering choice. And that doesn't mean an infinite number of choices, but offering even a forced choice of, do you want this, or do you want this now or in 5 minutes? That allows some empowerment, so that way people have choice about what happens to them. And also building on strengths is super, super important here as well. So what are your patient's strengths? What are the family strengths? So that way we can capitalize on those. Next, we think about collaboration. So here, patients and families really are active members of their treatment team. And that we are asking them about what their goals and priorities are. We're asking them how they can be supported. And this also means allowing opportunity for questions, inviting questions, kind of going back to that FAWN response. If you have somebody who's in the habit of people pleasing because that's how they've learned to survive, you need to allow them space to be able to ask a question or to have a difference of opinion. And so collaboration is actually inviting a difference of opinion in many cases, and giving a safe space for somebody to do that, and letting people know how to go about, escalating that they might have a difference of opinion or want something to happen differently. All of that's part of collaboration. And then also think about among staff, leveling power differences between different disciplines, between staff and administration. So that way people really are working together as a team rather than not feeling empowered to take ownership of what they can. Next is peer support. So we have a number of things already within our system that allow families to have some support of each other. And I think this is probably a place that we could all improve. But this is really about connecting people to those who have other lived similar experiences. And this might be directing families to like a Facebook group as an example. I know that that's been helpful for many families that have been through here, is getting on those Facebook groups for kids who have complex medical needs, or for kids who have an autism spectrum disorder as an example. Having support from other families who've lived through something similar is hugely, hugely helpful. And then I also think about tapping into our family advisory board and really hearing about what those folks' perspectives are on what we need is hugely helpful here. And then also think about how we can make sure that staff are getting support too. So connecting staff to the support for their work that they're doing. At Seattle Children use the WAVE tool as a way of recognizing when people are doing good work. I think those types of small gestures really can make a big impact, and also have a number of ways to get staff connected to our staff support team if needed. The last principle that we're going to talk about is history, gender, and culture. And here, I really think about the ways in which we need to level power differences. And so inherently, by being a staff member in a medical facility, we have power, and our patients and their caregivers have less in that setting. And what we need to consider is the ways in which history, gender, race, culture all interact and kind of come together in the medical setting, right? So paying attention to things like the ways in which there's been institutional racism in medicine, and having a good understanding of that. So that way we can understand potentially where somebody might be coming from if they have hesitancy around a vaccine, for example. So that way we are responding from a place of compassion and understanding. It also means recognizing the ways in which our own demographic variables can have an impact on somebody else, right? So myself as a white person in an institution that has a lot of power, as somebody who has lots of letters behind my name, understanding that in many ways I'm less likely to have a patient question my authority on things and ask a question. And so therefore, I really need to make a lot of effort to make sure that patients and their families know that they can ask questions of me, and that they can Talk to me about things that are not going so well. Because if I don't make those efforts, there might be lots of things that are being missed because of my relative power in the situation, right? So all of these are really important ways to help us understand the ways in which we as a system, because of systemic racism, might be inflicting trauma because of racism, bias, discrimination, and then also help us recognize our own power and privilege and the impact too then of our perception of someone's trauma response. So checking ourselves of, okay, am I perceiving this kid as an example as really aggressive? Or am I perceiving him as more aggressive than another kid who might be having the same behavior, but this kid is Black and this kid is white? And I've been socialized to perceive behavior differently for a Black child than for a white child, right? So paying attention to all of those things in ourselves, so that way we can pay attention to our own stress response, knowing that when we are in a place where we're responding from stress, we're more likely to respond in a biased way as well. So we've got to pay attention to all of those things. All right, our last R is resisting re-traumatization. So the important things here for me to think about is that systems can really unintentionally repeat the dynamics of a traumatic experience for someone, and that we can do it unintentionally. So we may not mean to create trauma for somebody, and the reality is that the interventions that we do can be necessary and life-saving, but they can be traumatic, right? So many of the things that might happen in medicine are potentially painful. A needle draw, a vaccine, all of those things are important and necessary. We're not going to not do them because they could potentially be traumatic. And we need to think about what are the things that we can do in order to prevent them from being traumatic for somebody. So for example, back to my kiddo who does not like the doctor. He hates shots. When he got his COVID vaccine here at Seattle Children's, one of the things that we did is we had Child Life come help. And if you don't know, Child Life just hangs out in the vaccine clinic right now, which is wonderful. And they were really wonderful in helping him get distracted and use distraction as a way so he wasn't fully paying attention to what was going on, talking him through so he knew what to expect, all of those types of things that were really nicely trauma informed that made it a much more pleasant experience for him rather than me having to hold him down so that way he gets the shot. He, watched an iPad and held on to his bunny, and it was painful. He didn't like it. He still cried, but it wasn't as potentially traumatic as it could have been if we just like held him down and shoved the needle in his arm, right? So there are lots of ways that, yes, we still need to do the same intervention, but if we can do it in a slightly different way, we can potentially reduce or eliminate the amount of trauma somebody's experiencing. My take-home messages for you are that we have this universal expectation. Everyone we encounter has experienced something potentially traumatic, and that trauma responses are normal reactions to abnormal events. And so if you can think about just those two things, if that's all you take home today, my hope is that that can help you change your perspective on some really difficult behaviors that you might see with patients, with caregivers, other staff members, or even in yourself, and then think about how we could respond differently. So what I'll leave you with and ask you to think about is what's one thing you can do in your next shift that is trauma informed. And you will have access to all of these potential resources. NCTSN is my favorite one. They've got lots of little pamphlets for medical professionals. I've linked here a number of things that are really useful, as well as some books. Trauma Stewardship is one that I will call out, which is a really nice book about working with people who've experienced something traumatic, working in healthcare, working in environments where you see hard things, as well as some things for kids and families that can be really useful. So I'm going to stop sharing and happy to chat more and answer any questions.
Please type your questions in the chat and I can read them out loud for Dr. Thompson. And maybe as people are thinking of their own questions, I go back to your slide on impact of trauma on staff, because, we're all human and we all have had our own experiences with traumatic events. And so then you come to work and you experience these things, like you said, like that secondary trauma. And we're hearing, I feel like the big thing right now is like burnout, right? People leaving healthcare So what are some things that we can do for ourselves to, I guess, alleviate that? Or I'm not sure what we can do for ourselves and our peers to help that, what we're feeling right now.
That is a great question. And my initial response and thought is that I am really tired of people saying you need to have better self-care to manage all of these really impossible things. I think I could spout off all the ways, like here are all the nice ways that you can take care of yourself. And I think at this point, people have heard like, yes, going to yoga is great and eating healthy is great and watching your favorite TV show. All of those things are helpful. And I also think that the piece that is key with burnout is what are we as a hospital community doing to support one another, from the top down and from the bottom up, and how do we as a system make sure that we are putting practices into place that are trauma informed not only for our patients but also for our staff, so that way staff are getting the support that they need rather than having to just do it on their own. Because I think when you are burned out, the last thing that I want to do when I'm burned out is like go do some exercise. Will exercise help improve my mood? Absolutely. Will it be the thing that I want to do when I'm so exhausted from a hard day of work? No. And so I think that in our like larger society, we've leaned so heavy on like, here are all the things you need to do to take care of yourself, and self-care has become this thing that like is this buzzword. And I think we've swung too far on like making people responsible for their burnout when that is one piece. Self-care is a piece, but we also have to have the like community care too. And sometimes that community care is within your family. And also we need to do that as a hospital system too, and think about how we do take care of one another. And so we have a lot of things already in place, like the employee assistance program would be something that I would highlight. The staff support team would be another place that I would highlight that, and really taking advantage of those things that already are in place in the hospital system. I think that people don't always know that those exist. And I think that it's also something we need to think about in teams is like, well, how do we make sure that we have enough staffing? And I know right now staffing across every department in the hospital is hard, but how do we like staff in a way that isn't burning people out, and make sure that we can switch people off so they don't necessarily have to have the hardest assignment every time? Like figuring out all of those things as managers and directors of programs, so that way we can build resilience in our team, not by just asking people to do more self-care. Do you know what I mean?
Mm-hmm.
Got on a little bit of a soapbox.
Yeah, there's a comment in the chat saying, I appreciate that you saying self-care is not the solution. And it's absolutely right. I think I am, when you're tired, you don't want to do more exercising, that's for sure.
Mm-hmm.
And thank you for acknowledging us being responsible for our own burnout, for being responsible for our own burnout. So I guess maybe like the responses, now that we know like what some of these are, and maybe some of the more atypical ones that people don't know, commonly know about, what is your like strategy then if you recognize that? What questions should we be asking to then, navigate and manage that reaction from a patient or a caregiver or staff?
Yeah, I think the first,
provide that care.
Yeah, that's a great question. I think the first thing is like getting curious and asking things like, hey, I'm noticing you're having a hard time. Validating, can't blame you. This is a really hard situation. How can I support and help you in this moment? And it might be that you're the trigger. So maybe because you're the one who delivered hard news, as an example, right? It may mean that you need to switch out with somebody else, and that's okay. We don't all have to be the ones to solve everything all the time. So switching out can be potentially helpful. And I also think a quick check-in with ourselves first, noticing like, okay, this person is starting to yell at me. I'm noticing my stress response go off. So before you even respond, taking a breath, noticing in yourself how you're responding. So that way you can get curious about the behavior rather than responding from your own stress response, right? Because then that just snowballs. Because then if you get angry and yell back, then it's just become you activating their stress response that's already activated, and vice versa. And just snowballs and gets bigger and bigger. But I think asking what they need and acknowledging that things are hard is a really good place to start. It's not going to be perfect. It's not going to mean that like everything. And lots of times people will tell you what they need. Sometimes they'll tell you, I need you to get out of my face. And then you're like, okay, I'm going to get out of your face. I'm going to give you some space and I'll have somebody else come check back in with you in 5 to 10 minutes, you know? That's okay too. We don't have to be present in that moment if they're having a hard time. We can give them their space and supervise if it's a kid who needs observation as an example. We can observe from outside from a window as an example. We don't have to be in their space right in the middle of everything in that moment. Does that answer your question?
Yeah, thank you. Appreciate that. All right. I think that may be all of our questions for today. And just so everyone knows, this talk was recorded and it will be available on our online video library at a later date. Some comments in the chat. Fantastic presentation. I learned so much, and thank you, Dr. Thompson.
Thanks so much for having me.
Thank you, everyone.
Have a good day.